I practice emergency medicine, trained in emergency medicine, and then I trained in critical care and then in health policy research. And I now we're bringing two worlds together in the emergency department, a policy research shop that we have and our Center for Resuscitation Science, so that we can start to think about how to build a system to deliver care for people with unplanned critical illness. I see people squinting at it already, so I'll talk about it just for a second. Unplanned critical illness is the stuff that you don't want, strokes and cardiac arrest and the special kinds of heart attacks and bad bloodstream infections called sepsis. But the other piece about it is it's the piece that a lot of doctors don't really want either. It's unplanned. It's terrible. It happens in the middle of the night and weekends. I sat at my kid's baseball practice yesterday in the car with my headphones on and my Wi-Fi hotspot, resuscitating a patient with cardiac arrest for 45 minutes. It's really inconvenient, and that has been a great opportunity for us to think about how we match supply and demand. I overlap with, a little bit, the tele-ICU folks you heard from Ben Cole, and with the stroke folks you heard from Mike Mullen, both colleagues and friends. We focus less on the patient's behavior and more on the provider's behavior. So you saw a similar map that Mike put up. This is sort of a nameless map. It happens to be the trauma system, but that doesn't really matter. It's these travel sheds of how people get to care, the right care. And we have used a lot of time and energy thinking about how to build this system. We built specialty centers. Those are the red dots. We thought about transport networks, as old-fashioned as lights and sirens, going fast, not stopping, and ambulances. We then started to build web pages that allow you to interactively play with your system so that you can meet with state planners and they can look at how they might build a more strategic system. We let them sort of drop and drag a helicopter depot or an air ambulance depot into any place that you're allowed to land a helicopter so they can see how that changes their flow of patients. The whole piece is we've been bringing the patient to the provider, and everybody today is on the same page about bringing the provider to the patient. And when it is wireless monitoring, it makes good sense. When I try to frame this in terms of managing a population, thinking about a population who need hands-on care, it becomes a little bit trickier. For all the work that we've done building this system, and trauma is arguably the most developed, about 50% of severely injured folks in the United States end up at a trauma center. I could tell you similar numbers for cardiac arrest, for severe sepsis, for stroke. They're all abysmal. But the goal, obviously, today is to think about what we can do in the technology space to change this. One of the ways we've done that is we chose a disease, even though it hurts me a little bit to choose a disease, right? We chose cardiac arrest because it's important, because we have the Center for Resuscitation Science, because we're really, really good at it here. And we went and asked folks in smaller emergency departments, how can we help you with this disease? So what are the barriers associated with providing advanced resuscitation in the emergency department? Lots of people said there's no barriers. Some of them said, I don't know how to do it. And then some of them, I don't really know what this means. It require too much time in the ED as opposed to, just sending them to transferring them out. Their administrators, you can imagine, have a different vision on that. They would like them to not be transferred out. And insufficient staffing. I mean, I would argue, as we get to telehealth here, that we can talk to all of this, right? As we start to put a new person in the room to help out, as we start to walk them through it, right? As we start to maybe relieve the provider who says it's too much time, I can't do it. Relieve the provider and put a new provider in there at the bedside with them. And then finally, before we talk about what we've been doing, we said, how could it be helpful? And I will tell you that in our pilot, I will walk through each of these briefly, step-by-step instructions, so you get a totally green person in there. You're standing there watching and talking. You help to decide who it's good for, make sure they get the right medications. You sort of heard that story from Ben a little bit earlier today. For those of you who follow the emergency department crowding world, there's a lot of patients that spend a lot of time in the emergency department. We can be there with them providing critical care services. We can make sure that they're adhering to protocols. We can troubleshoot problems. We've been working with the Reach company, piggybacking on some of the stroke work. This is an older version of their Carr, but so there's this monitor with their with the electronic medical record that doesn't exist. We're helping them to build this. On the other side is a monitor that's pointing at the patient, along with the camera pointing at the patient. You'll see it out there. So the patient just sees me talking with them. I have control over this camera, and on the other side, the nurse standing here largely is looking at me and looking at the patient and looking at what will be someday when we build out the electronic medical record. So we built a system that alerts us when someone presents with a cardiac arrest, or someone presents that might want some resuscitative skills. We've let it be a little bit flexible because we're interested in doing a lot of pilot work. And so we all get paged and we respond as quickly as possible. The cart automatically pages us when someone enrolls it. We The logistics of it are very, very malleable. We've had really good uptake of it, and then we pop in, right? So this is now me just on the 4 screens. I'm sitting in my office in Blockley. Anisha's over in Penn Tower. Sarah is in her house. And the patient and the nurse are obviously here. The resident is over here somewhere. So this is sort of a macro view of the room. But I have pretty good control in this camera. You'll see it out there. I can watch their vitals in real time. I can zoom in and take a look at the ultrasound. In fact, we could plug an ultrasound. A lot of these devices can plug an ultrasound in so they could be in real time. I'm not touching the probe, but they don't need me to touch it. They need me to say, yeah, I agree. No. Sweep through that one more time. I agree. You're right. Right? And then this is, one of the techs took this. I'm at home. It's 3 o'clock in the morning. You can tell I'm squinting and unshowered. And this is one of the fellows from Children's Hospital in Pediatric Emergency Medicine. She's a pediatrician training in peds emergency medicine, rotating through our emergency department. She's putting an arterial line in a patient who had a cardiac arrest. Pediatricians don't do that so much. But, she is. So this is her ultrasound probe. She's just switched it off. This is, I'm having a hard time seeing, this is her monitor. She's looking at her ultrasound. Here's my camera. I'm looking at her ultrasound, I'm going back and forth to her field, and I'm talking her through this the entirety of the time. So I'm not the only one who thinks about how we think strategically about covering, how we think strategically about improving access to care. But I would argue that the systems that we are building around these diseases, this one mostly referring to trauma, but around these other things, are not sort of ready for the future, and there is a really aggressive way that we can start to lead and to get us there.